Adelaide Shoulder and Upper Limb Clinic. Innovative leaders in the diagnosis, treatment and surgery of the shoulder, elbow, wrist and hand in South Australia.
Hi, I'm Oscar Brumby-Rendell, upper limb surgeon specialising in shoulder, elbow, hand and wrist. The purpose of today's video is to demonstrate a systematic approach to a brachial plexus examination. This is typically injured from a tractional type injury lateral to the roots of the neck, or a high traumatic scenario like a car accident. We'll also go over the myotomes and dermatomes of the cervical spine, which is more commonly a spinal injury assessment, which is performed rapidly. Specific equipment for this examination involves a tendon hammer to elicit the tendon reflexes whilst performing the examination. Before seeing the patient, you also want to ensure that you have relevant exposure. It's important to be able to see from the back of the shoulder to see the scapular and the periscapular muscles all the way down to the hand. As always, before assessing a patient, you should perform hand hygiene. And lastly, be sure to introduce yourself and ensure the patient is happy for you to commence the assessment. Hi Danny, my name's Oscar. Is it okay if I assess your upper limb nerves today?
Yes.
Great, we're ready to begin. The brachial plexus examination can take the same template of look, feel, move special test. However, the feel and move components are often done at the same time as we test the nerve's sensation and motor simultaneously. We'll start with look. As we do a general inspection, I ask the patient to just stand and place their arms in the anatomical position. Just from this position alone, you can gather quite a lot of information if there's any deficits. If the patient is unable to externally rotate and hold that position, that can indicate straight away they may have a lesion at the C5-6 level, limiting their ability to externally rotate the shoulder. You can also see quickly the hypothenar and thenar eminence of the hand, looking for any subtle signs of weakness. I then move around to look from the front of the patient, looking for any signs of asymmetry of the deltoid musculature at the front of the shoulder. Also in this position, just looking for any signs of scars or obvious signs of previous trauma. In this position as well, we can assess for a Horner's syndrome, looking for signs of meiosis, ptosis and anhidrosis. I then ask the patient to turn and face the other wall, looking from the side. This can give you another perspective on the deltoid musculature, and you start to see the periscapular muscles as well. I then ask the patient to face this wall to the left and looking at the periscapular muscles. It's important just to visualize the scapulars, and we're looking at both the supra and infrascapular fossa for the supra and infraspinatus muscle. This is often pretty obvious when you have a lesion here with a strong asymmetry between the two muscles. You will see a scalloping out of the fossas here due to muscle weakness. I'll then get the patient to face forward again, and then we'll now move on to the direct testing of the nerves of the brachial plexus. The brachial plexus is a complex connection of the nerves from the cervical nerve roots all the way to the peripheral nerves of the hand. It's important to have a good framework to examine this systematically so you don't miss anything. The brachial plexus is divided up into sections. They are the roots, the trunks, the divisions, the cords, and finally the branches. Our examination centres around examining the nerves that come off at each of these levels. This helps so you don't miss anything. We're going to start with examining the nerves that arise from the roots. We'll start with examining the dorsal scapular nerve, which comes off the nerve root C5. This is the nerve that supplies the rhomboid muscles, which helps retract the scapula. This is best assessed by asking the patient to squeeze your hand that you place in between your scapula at the back and looking for symmetrical movements. Danny, I'll just ask you to turn around for me. So placing your hand in the middle of the back, please pull your shoulder blades back, attempting to squeeze my hand in between your shoulder blades. We're looking for symmetrical motion here at the scapula. Thanks. Turn back around. Next is the nerve to subclavius, which arises from the C5 and C6 nerve roots. This nerve is unable to be tested as it supplies the subclavius muscles, which motion can't be isolated. Following that, we have the long thoracic nerve, which arises from C5, 6 and 7. This supplies the serratus anterior muscle, which helps protract the scapula around the thoracic wall. This can be best done by asking the patient to extend their arms out and pushing against the wall. I'll ask Danny now to turn around and with their arms facing forward, pushing on the wall, and we're looking for the scapula to motion around the thorax. If there's a palsy of the long thoracic nerve, this causes winging of the scapula, which is normally very obvious. What we'll see as Danny tries to push forward, that one scapula will move around and the other will stay more central on the back and will even lift off. Next, we'll assess the nerves that arise from the trunks. There's only one, and that is the suprascapular nerve, which supplies the supraspinatus and infraspinatus muscle arising from C5 and C6. The infraspinatus is the last muscle to be innervated by this nerve, so it's the best one to be tested. This is done by asking the patient to externally rotate the shoulder and pushing against them to see if they can maintain that against resistance. What we're looking for here is intact motor power, weakness, or complete absence. You can have a partial nerve injury so that the muscle is still able to fire but is weaker than usual. Danny, I'll just get you to hold your arm in, elbow against your chest, and then externally rotate out. Good. We already partially screened this at the start from our general inspection when we demonstrated that Danny was able to hold that normal anatomical position. But now we'll test that she can maintain this against resistance. Hold that there, keep it there, and don't let me move it. And that is intact. We're also palpating the infrascapular fossa at the same time. This is where the infraspinatus muscle is, and we can really feel that tense as we push against resistance, further confirming that that muscle is activating. Next is the divisions of the brachial plexus, of which there's no nerves that arise from. This then is another anatomical separation point. So far, we've only tested nerves that arrive from the supraclavicular region of the brachial plexus. The nerves that we test from now on will be from the infraclavicular region, and they are the nerves from the cords. We'll now examine the nerves that arise from the cords. The cords are further divided into three. They are the lateral cord, the posterior cord, and the medial cord. There are 3 nerves that arise from the lateral cord, 5 that arise from the medial, and 5 that arise from the posterior cord. We'll start with the lateral cord. There are 3 nerves that arise from the lateral cord. They are the musculocutaneous, which is C5, C6, the lateral contribution to the median nerve, C5, C6, C7, and the lateral pectoral nerve, which is C5, C6, C7. We'll start with the musculocutaneous nerve. This is best assessed by assessing their biceps function, holding the arm in a supinated position and the elbow at 90 degrees. Then ask the patient to hold it there, keep it there, and don't let me move it. And trying to extend the elbow. We're looking at the biceps muscle and assessing for that to be tensing whilst we assess this. There are lots of muscles that can cause flexion of the elbow, so it's important to look at the biceps muscle and ensure it is contracting whilst you're testing it. This is intact here. When assessing the lateral contribution to the median nerve, the FCR muscle is the best to test. This is done by placing the hand in a more radial deviated position to try and help isolate the wrist as we move it into a resisted flexed position. So asking the patient to hold their wrist as such, moving it across into a more radial deviated wrist position, asking them to hold it there, keep it there, whilst you then supply an extensive moment against the wrist. Again, palpating the FCR to ensure that it's activating. Good. The lateral pectoral nerve supplies the clavicular head of the pectoralis major muscle. This is best done by asking the patient to place their hands on their hips and squeezing that down. If you do this yourself, you can feel your pec muscle tense. You then want to feel for the clavicular head, which is more superior of the pectoralis major muscle as opposed to the sternal head. So asking the patient to do as such and squeezing down against them tight. We then want to feel here and then try to pull their elbow off their body. And we can feel that's nice and strong. That concludes the lateral cord. Next, we'll test the nerves from the posterior cord, of which there's 5. The axillary nerve, which is C5, the radial nerve, which is C5, 6, 7, C8 and T1, but we'll be only testing the extensor indicis muscle, which is C7, 8, the thoracal dorsal nerve, which supplies lat dorsi at C7, 8, and then the upper and lower subscap nerve, which can be grouped together just to test the one muscle, subscapularis. We'll start with the axillary nerve and C5. This is best by asking the patient to hold their arm in a fully extended position and asking them to forward elevate the arm whilst you palpate the front of the shoulder, isolating the anterior deltoid. Hold your arm there, keep it there, and don't let me move it. Good, and you can feel the anterior deltoid tensing there. We'll then move into an extended position, so just go relax there for me, Danny, and bring your arm back. Now hold your arm there, keep it there, and don't let me move it as we try and flex at the elbow, and that isolates the posterior head of the deltoid better, and that's intact. We'll next to test the subscapularis, which is C5, C6. This is best done with internal rotation, doing the belly press maneuver. Bring the arm forward, making sure the elbow is anterior to the chest so they don't recruit more of their pec major. We then want to put your hand underneath the wrist and ask the patient to hold their wrist up against their belly as you try and move it away. She's able to maintain that position there, indicating the intact muscle. Next, we'll test the thoracic dorsal nerve. This supplies the lat dorso muscle, which can be a little bit tricky to isolate and feel. Some textbooks suggest asking the patient to place their hand on their side and asking them to cough whilst palpating. This can sometimes be a bit awkward. Another way to isolate it is to bring the elbow out to the side of the patient, ask the patient to hold it there and keep it there as you try and further abduct it away. With your other hand, you're placing it in the posterior aspect of their scapula, feeling the lat dorso muscle contract. Hold it there, keep it there, don't let me move it. We can feel that contracting there nicely, and that is strong. Next, we'll test the radial nerve. The radial nerve supplies many muscles. We want to test the last muscle that it innervates so that we have a higher pickup rate of assessing any dysfunction. That is the extensor innersus muscle. What we want to do is ask the patient to hold their wrist out, flexing the other fingers whilst they extend their index finger in particular. We then ask them to hold it there, keep it there, and don't let me move it. And we can see that's intact and strong. This concludes the examination of the posterior cord. Next, we'll test the nerves that arise from the medial cord, of which there's 5. The medial contribution to the median nerve, which is testing the abductor pollicis brevis muscle, the ulnar nerve testing the first dorsal interossei, the medial pectoral nerve, which is the sternal part of the pectoral major, and then 2 sensory nerves only, which are the medial cutaneous nerve of the arm and medial cutaneous nerve of the forearm. All these nerves originate from C8-T1. We'll start with the medial contribution to median nerve and testing abductor pollicis brevis. We just ask the patient to hold their hand out, and then I like to turn it into a neutral position and bring the thumb out into an abducted position. Ask them to hold it there, keep it there, and not let you move it as you try and bring it back towards the index finger. Your other hand is then used to palpate the thenar muscles. You can feel that tensing strongly as they move against your resistance. Next, we'll test the ulnar nerve. The muscle to test here is the first dorsal interossei. This is the last muscle innervated by the ulnar nerve. Again, in that same position, ask the patient to raise their index finger and to point it up towards the ceiling. As you do that, you do see a bulge of the first dorsal interossei in the first web space. Ask them to keep it there, hold it there, and don't let you move it as you try and bring it towards the middle finger. Again, using your other finger to assess for the tensing of the first dorsal interossei. The medial pectoral nerve is assessed the same way as the lateral pectoral nerve, only you're palpating more centrally over the sternal head. Ask the patient to place their hands on their hips, to squeeze that down tight, like they're bringing their hands into their hips, whilst you palpate the sternal part of the pectoral major muscle. Finally, we test the sensation of the medial cutaneous nerve of the arm and the forearm by asking if they have normal sensation to the medial aspect of the arm and then the forearm. Can you feel me touching here, and is it normal?
Yes.
Can you feel me touching here, and is it normal?
Yep.
Sometimes patients say yes, they can feel it, even though it doesn't quite feel normal. It's important to discriminate between a normal sensation, abnormal sensation, and no sensation. This concludes the medial cord examination. At the end of that brachial plexus examination, you may need to further examine a specific nerve to isolate a location of nerve injury. For example, when testing the radial nerve, if the extensor indicis muscle was weak on examination, it would then be important to test further up the radial nerve. That would be first the wrist extension and then the elbow extension, as the triceps is the first muscle innervated by the radial nerve. This helps to localize where a potential lesion has occurred. If the triceps muscle is intact, but the wrist extension is not working, then the lesion is most likely at the level of the elbow. If there is a mixed picture of dysfunction, it may be that the nerve lesion is more proximal, coming from the spinal nerve roots, as opposed to a more distal brachial plexus type lesion. In that instance, you can perform a dedicated cervical nerve root exam. We do this through the ASIA, which stands for the American Spinal Injury Association. This has a framework for examining the cervical spine, which makes this quite straightforward. We examine the myotomes and the dermatomes for C5, 6, 7, 8 and T1, and then perform the tendon reflexes. First, I like to just test sensation for all nerve roots all at once, as this is done fairly quickly. C5 is lateral elbow, C6 is the thumb, C7 is the middle finger, C8 is the little finger, and T1 is the medial elbow. So when looking at the patient, ask them to put their hands out like so, and this can quickly be done. Can you feel me touching here? Does it feel normal?
Yes.
Here, does it feel normal?
Yes.
Here, does it feel normal?
Yep.
Here, does it feel normal?
Yep.
And here, does it feel normal? Yep. We have just tested the sensation for C5 to T1 that quickly. We'll now perform the motor part of that exam with C5, 6, 7, 8, T1. C5 is elbow flexion, C6 is wrist extension, C7 elbow extension, C8 middle finger flexion, and T1 little finger abduction. We'll start by asking the patient to place their hands and arms out like so. Hold it there, keep it there, and don't let me move it. And I'm trying to extend the elbow against resistance, looking for biceps activation. I normally skip straight to C7 because I'm already holding the elbow at this point, and ask the patient to straighten the elbow whilst I bend the arm up. I then turn the hand over and ask the patient to pull the wrist back as I push down. Hold it there, keep it there, and don't let me move it. Great. I then turn the hand over, try and make a fist. I then hold the middle finger and try and uncurl their hand out of the fist. Hold it there, keep it there, and don't let me move it. Good. Now spread your fingers apart, hold it there, keep it there, and don't let me move it as I try to squeeze their little fingers, purposely looking at the little finger there. Great. And that's the motor component of the C5-T1 cervical nerve root exam. If there's an abnormality whilst testing the motor function, it's important to grade this as per the ASIA guidelines from either 0 to 5. One of those steps is eliminating gravity to further assess the motor function. A way to do this when testing the elbow extension or triceps muscle is to bring the arm forward into a forward flex position and support the shoulder in that position. We now ask Danny to actively extend the elbow, which she can demonstrate there. This is eliminating the gravity for that muscle, and we can see that that active motion is intact. To further test this muscle now to see if it has motion against gravity is to bring the arm out in this position whilst gravity is active. Ask the patient to straighten the elbow now, which demonstrates motion against gravity. We then further test by seeing if she can do this against resistance, which we've already demonstrated previously. Finally, we test the reflexes. They are C5, C6 for the biceps. This is done by palpating the biceps tendon and then hitting your own fingers with the tendon hammer. The brachioradialis, also C5, C6, again palpating over the radial styloid and hitting your fingers with the tendon hammer. The triceps, which is C7, C8, again, you can use the tendon hammer directly onto the triceps tendon here, looking for the elbow extension. And finally, the Hoffman's test, which is holding the middle finger out in extension and flicking the distal interphalangeal joint and looking for reciprocal thumb flexion at that moment. If this is present, this indicates hyperreflexia. This concludes the brachial plexus and nerve root examination. This provides a systematic framework for you to work through from proximal to distal to try and isolate a level of potential nerve injury. It's important to follow this framework, otherwise it can be tricky and steps can be missed.
This presentation forms part of the Adelaide Shoulder and Upper Limb Clinic's online educational series. If you would like to view more of our online education materials, please visit our website asulc.com.au.